gives me great pride to introduce Professor Balicer and Professor Dagan from the Clalit Research Institute and Ben-Gurion University, who will be discussing apparently redesigning healthcare or integrating AI at the point of care. One of them.
Thank you so much, Noam. And it's wonderful to be here today. And what we'll try to do in the next hour and a half in this joint talk is to go through a very high-level, I would say, intro into the journey that we've been trying to take in Israel, trying to redesign and reinvent healthcare as we know it, because we generally feel it is failing. It's failing on the professionals, it's failing on its patient, it's failing on the future and sustainability, and we really have to be a little bold about visioning a new future and striving towards it. And let's begin. You probably know this guy. Who knows this guy? You know this guy.
This is the super alpha champion, right?
This is Lee Sedol. He's the world champion in Go. Those of you who do not play Go, I suspect there's one or two persons. It's the game that makes chess looks like child play. So if you have intellect, you don't play chess. You go ahead and you play Go, because that's in chess you can probably compute all of many potential futures in the board game. Here it's completely impossible. There are more potential moves than the atoms in the universe. So this is really for smart people. And this is the moment where Lee Sedol, which is the world champion, and he beat everyone and anyone who ever stood for him. This is the moment that he understands something has changed. And this is his famous competition against DeepMind's AlphaGo. And this is the point in the game when he says, oh God, this is not what I thought this will be. And this is the first game. And in the first game, who won? AlphaGo. And in the second game? AlphaGo. Third? No, AlphaGo. Fourth one, Lee Sedol won the game. And there was what is called the act of God, when he saw this specific move that no one could understand where it came from, and in the fifth he lost. So at the end of the day, 4-1 to the machine, and this is where we understood that nothing is going to be as it was. And this same, I think, moment right now is the moment that we as an industry are experiencing when we understand nothing is going to be as it was. And I'm going to read to you a post by one of our physicians. And he said about the system that we've deployed. He said, I saw this patient today. I said to him, this is what the system suggests. Let's do it. He followed through. And he cuts to at the end, he says, here's the truth. I wouldn't have ordered this test on my own. The system saw what I did not. It saved a life. So this is unprovoked. This is his own thing. And this is the point in which we understand that medicine is not going to be the same. And the reason it has to change is because, generally speaking, we're in a no-go situation. The patients are becoming increasingly older. Israel is a young country, but it's aging in a higher pace than any other country in the world because of its structure. In terms of the number of chronic conditions in every age groups, the number is high and increasing. So you can see some graphs here that suggest the uptrends of things like obesity, smoking that drive chronic diseases in every age group. It's a problem. And we do not have more clinicians than we did before. It's actually the other way around. There's right now a shortage of 10 million practitioners globally, and rich countries are stealing the professionals from the poorer countries, but there's a limit to how long this can take us. And so the gap is widening. So this is why this system, in general, is actually eating away both its staff and the wellness of the patients. And basically, the squeeze is increasing all the time. And there's a phenomenon called burnout, where physicians are basically getting out of the profession because it's becoming impossible, because the strain increases. You're expected to see more and more patients at any given time. And it's not feasible, basically. So good, well-intended systems are reaching their edge already now. It's not a futuristic thing. We've been saying this for a long time, but now we can see these things actually materializing in front of our eyes. Basically, you do not, when the demand goes up and the supply goes down, one of two things will happen. The system will fail, or you will change the system. There's no third option. And so for the first time in many, many years, this slide goes with me. People who have been with me for a while know this slide for at least 16 years now that says this is, the end is near. This will not hold for long. And this year was the first time that the Surgeon General of a country, in this case the United Kingdom, had these words in their strategic plan for this year. They said, we change or we die. And now this is an official statement by a big health system that we all learn to cherish because it's actually providing good care for the masses. So this is not a small change. We're talking about a real profound transformation of the basic of how care is being provided. And healthcare today is in a sorry state. At the end of the day, we provide late and reactive care. You don't have pain, you don't go to your physician, right? It's intuitive and exceedingly error-prone. We'll talk about some of the statistics today, but it's horrible. It's horrible. 1 of 4 people walking into a hospital leaves with iatrogenic damage caused by good intentions physicians who are doing what humans do, which is make mistakes. And there's increasingly long queues and a lot of waste. And what healthcare could look like is this: preventive in nature, predictive, proactive, where the care the decision of the care that we provide for every one of our patients is precise and personalized based on all of their available data and what we know about it from the literature. And something that is always on, accessible, and as much as possible, sparing for the provider's time, which is very precious. And small changes just won't cut it. We will need to make dramatic changes for this to work. So how does that new bold future looks like? Let me give you one example. So many of you know the disease called hepatitis C, which is a viral illness that resides in your bloodstream and is very silent until the point in which your liver stops functioning, at which point you get either cirrhosis or liver cancer, which are 2 of the worst ways to live this world. If you have to choose one, don't choose those. And so these are really serious, and they are completely preventable, because if we give there's new drugs which are 98.8% effective, and if you give the patients these drugs, they will be cured. They will not have liver cancer. They will not have liver cirrhosis. The only problem is, I don't know which one of you right now has hepatitis C, because it's completely, invisible. So every year we screen 50,000 people looking for those few cases, and we found 38, which is great. 38 people which will not have liver cancer, which will not have liver cirrhosis. And it's very effective, very cost effective. That's fantastic. Can we do better than 38 out of 50,000? So what we try to do is, try to use all of the data available in the health records in order to identify those at the highest risk of having right now hepatitis C in their bloodstream without any sign or symptom to tell us about it. And we went for the highest ranking 500, and we knocked on their door and say, would you be willing to come into the clinic so we can test to see if you have this, and how many? We would expect to have less than 1, right? You can do the, so how many did we find? Okay, so this is serious. This means we've improved a state-of-the-art screening process. This is based on the best guidelines of the Ministry of Health and the CDC and whomever. We've just improved healthcare 100-fold. How many times in your work in your life have you seen an improvement of a clinical process 100-fold? So basically what we do with this is we provide our clinicians with a superpower. And this is the promise of the current age. We will take the clinicians and allow them to do that what was not humanly possible before that. And so if you'll read the methodology of what we've done there, these are tools that were available 15 and 20 years ago. This is not transformer-based. This is not state-of-the-art LLMs. This is not foundation models. This is good old machine learning. Anybody could have done this 20 years ago. You just didn't. And we were fortunate enough to have access to 5 million lives that we care for as Clalit, cradle to grave. And we have a very deep and meaningful data source that's 25 years long. And you can actually do these types of exercises of looking at patients 10 years back, 15 years back, and do a retrospective assessment in order to create new predictive models and then put them into practice and see how they work. And you can do this systematically, which we did. And our aim at the end of the day is very simple. Instead of walking to your clinic with your pain, you'd like your clinicians to call you in the morning. Good morning. Good morning. How are you? I'm fine. Why are you calling me? Well, you know, our data suggests you might have a heart attack in the coming week. Would you mind coming for a visit sometime so we can prevent this? Funny, right? You know, that's science fiction. That's not real healthcare. That's not how healthcare works. Only that it does. Exactly like that. Exactly like that. We've started doing this as early as 2010. In 2010, we've created the first of these predictive models identifying patients that will 5 years from now will have kidney failure, and we approached them when they looked well and they felt well, and not in the point in time that they needed dialysis. You know how debilitating this condition is. So we found them as early as that, and we approached them, and we have intervened patient by patient with Excel lists sent by email, but still, it worked. Since 2014, when our nurses in our clinics need to bring their patients in for their flu shots, instead of calling them by their age or any other thing that you'd like to imagine people are called, usually just arbitrarily, but whomever answers the phone, we've created lists for those nurses that rank all of their population according to the risk of having pneumonia this winter driven by flu. So you call them not according to their age group, but according to the potential benefit that they would get from getting this vaccine. And this is done now for 11 years in a row at Clalit. This is not a new thing. By the way, what is the single most important predictor of that? You have one feature. I will give you one feature. Which is the feature that you select?
In the past.
Sorry?
Having pneumonia in the past.
That is absolutely correct. That is the one thing. If you've had, and why is that true? Why would that be the most important feature? Obviously, you'd say that's because it shows some kind of a immune problem or something like that. But we've done some exploring, and we found that the most important thing is that this means you're in the center of a network of people that transmits flu. So think about it for a second. If you're a hermit living in a cave and you're very old and fragile, your chances of this are lower than a kindergarten teacher with intact immune system, because of the likelihood of you experiencing flu when you're a kindergarten teacher is approximately 100%. Anybody who has small kids know what I'm talking about. Okay, so 10 years fast forward, and the same thing is now done with a foundation model that is able to do 1,500 zero-shot predictions based on whatever embeddings of the patient data in an embedding space and finding similarity patterns. But who cares? It's not about the technology. It's not about the methodology we're using. It's about the willingness to use this type of data for this type of purpose. And basically, it's about a change of paradigm from patient-level reactive therapeutics as an approach to population health, real population health, predictive, proactive, and preventive. And that is a paradigm shift. Basically, it only means that you will treat, some of you, most of you have cars, some of you have a whole fleet of cars in your respective institutions. Would you have your system running the following way? You drive and you drive and you drive, and when there's smoke coming out of the engine, that's when you go to the shop. Would anybody use this approach for their car? Don't raise your hand at this point, okay? You're not, right? Because, it's your car. You will not have breakage maintenance for your car. It's expensive. But this is how you run the healthcare of your loved ones and yourself and your health system. If there's no smoke, you keep going until you're in pain or disutility. So that doesn't make sense, right? This is how we should treat healthcare, but we don't. And in order to do this in a systematic way, we tried to create what is termed as a learning healthcare system, a whole process by which you define the need, you develop the potential solution based on the data and the tools that you have in place. You test those solutions in silico to see that they actually provide the predictive or inference that you need. You select the ones that the organization is willing to sign off. You deploy it in the clinical setting. You evaluate it for its real-life impact, and then you scale. Simple. but very difficult to happen in real world settings. And we were fortunate enough to be able to do this. And the first time this came like into, when it hit the fan, was during COVID. So when COVID came in, as early as March or even February, Noam, you'll remind me, I can't remember when this came in. But in January, we heard the news. We had data that came from China and Italy. That's all we had. Mortality data coming from China and Italy. And we had our flu model running for quite a while. And at that point in time, we said, do you know what we're going to do with COVID? Exactly what we do with everything else. We will do predict, we will do prevent, we will do proactive approach to a disease we know nothing about. So how do you do this for something? And we'll use the amazing database of nothing, because nobody had a database about COVID at that time. So how do you do that when you have zero data at hand? Well, basically what was done was taking the available data on our flu model and adapting it, nudging it slightly to fit the mortality patterns of what we've seen in China and Italy for the new disease called COVID. And we had a predictive model by March working. And we have called 200,000 individuals in Israel, personally called, and we tracked them one by one. And they all got a call and said, there's a new disease called Corona. You've never heard of it. You might stay at home. This is not a good time to go to anything, to work, to parties, whatever. And it was before anybody understood what's happening. And by that time, they stayed home, and there's mortality data to suggest that the mortality level in those months in Israel was lower than almost any other country in the world. And it's not because we didn't have it. We were the fourth ones to actually experience COVID. It was because actions like this, predictive, proactive. And when a patient walked into a clinic by April, their physicians had a pop-up that says, this patient that just walked in with a headache, he actually might have COVID. How did we do this? According to the data from where he lived and the amount of data we knew about who is sick around him, and it said that we flagged him. There wasn't any such system anywhere around the world, I promise you. Not even close. This was working in real time. And a year later, the vaccines came in. We started vaccinating. And in the same time we were vaccinating, we had a huge surge of COVID. And it almost reached capacity in our ICUs. And we said, what do we do next? Okay, what do we do next? And it could be that we said, well, we vaccinated, so we can lax the quarantine. We can lax the quarantine that was happening because we vaccinated, going to be fine. We could say, this is just like this. It starts off, and then it goes up. So this starts off, and this is what we're going to see now. So you basically need to predict what happens next. And if you're wrong, if you stop the closure and it ticks up, we're going to see horrendous sights in this country. And if we're right, then it's great. This is what happened when the same decision was made in Hong Kong. They couldn't get the patients out of the ICUs. They were keeping the bodies on the floor because they didn't have enough staff to keep the bodies out of the ICUs. So this is the wrong decision. This is what happens if you go wrong with this. So this is, and I was at that time part of the Israeli cabinet making those decisions on a daily basis, and I definitely would have paid the price for making any wrong decision on that. So nothing easier. All you need to do is take those who got vaccinated, those who didn't get vaccinated, compare them, and that's it, right? It's you just compare what happens, and you'll know if the vaccines work or do not work. Well, those of us who are a little bit into epidemiology know that it's not so simple, because there are many, many basic differences between those who get vaccinated and those who do not. You can just compare them head to head. So to reinvent a whole methodology of doing this, unfortunately, we were working with amazing laureates with Miguel Hernan and Mark Lipsitch from Harvard, and Ben Rice and Noam and Noah, who spearheaded this work. And we were actually doing what today is considered the digital twin approach, where we try to create people who are the same, except that there were those who did not get the vaccine. And there was a rolling cohort where you take those identical people, one vaccinated, one unvaccinated, you follow them until one of them gets vaccinated, and at that point in time, his virtual friend goes away, and you combine him with another digital twin at that point, because now he's a different group. So you do this time-wise, and you keep on doing this. And so you have something that would emulate the trial to some extent. You might think about it, this approach. And we had a lot of tricks trying to understand whether we did this correctly in order to make sure that we meet all of the causal inference criteria. And we looked at the beginning period where you would expect zero impact of the vaccines to make sure that the lines still were matching, and a lot of others methodologies trying to do this the right way. And we came up with a response that says this is probably 94% effective in preventing severe illness, 94%, which is amazing, which means the vaccines actually work, first evidence in the world for this, and we published this, and based on this decision, amongst others, we decided to open the lockdown. And what happened? It went down. If it was the wrong decision, we would have had a very different talk right now. But we took the decision, we opened the lockdown, and in hindsight, thank God. But this is high stake inference in real time. And then about 5 months later, the results came in of the actual trial we did at the time. Not trial, but the active follow-up of patients in 6 hospitals. And the vaccine effectiveness was 94%. So of all of those who said, these were bogus trials and you can't trust the retrospective, well, apparently you can. Apparently you can, and in real time. So there was a whole set of papers later that came in using this methodology, but the most important one was the one who suggested the third of the dose of the vaccine is critical. And in this country, like many others, a decision was made to vaccinate the entire population with 0 clinical trials. Never ever in modern history have we seen a intervention put into practice at scale in the United States and in many other countries without a clinical trial to suggest its effectiveness. And the decision was made based on Clalit data. So talking about high stakes, fairly high stakes on how to use data in order to make decisions. And this approach now can be used in many different other ways, because if you think about it, within our data, we have a lot of digital twins in which we can kind of see what happens to them when they make decisions and their physicians make decisions. And if we do this properly, there's a lot of inference we could potentially do, but we should do this very carefully, because these type of retrospective data are really easy to do, and they are straightforward, very crisp, and exceedingly wrong. If you want to do these types of studies with a causal inference in mind, you have to do a whole lot of effort in order to do this right. But at the end of the day, this gives our physicians another superpower, which is to know what works and what does not. And I'm afraid to tell you that today, as policymakers, we're flying blind. We have no clue what actually works in practice. You all think we do evidence-based practice. You are dead wrong. In most cases, we have no clinical studies to suggest that this patient that I'm treating today in my clinic should get treatment A versus treatment B, and whatever clinical trial that was done 5 years ago in a wholly different population, shown on average some kind of advantage, means nothing about the right decision for this patient at this time. And we can change practice if we do this correctly, because we do have the data now to be able to tell us that. So we can do this at scale. To take another example of how this can be used in order to improve practice, we have a problem called no-show. I don't know if you know of this. 25% of the people that are supposed to come to your very busy clinic decide not to show up. Lots of reasons. But that's everywhere, anywhere. That's always the number. 25% do not show up. This is a huge burden on the system. What can you do about it? Well, what about if you send them an SMS saying, if you're not coming, just let us know. Be kind. Just let us know in advance and we will figure out what to do with it. So we had those SMSs, and what was the success? 0. No effect. They ignored the SMS as they ignored the original kind of, they couldn't care less. Okay, so that doesn't work. But what if you could design a message that would hit a soft spot for the patient? And different people have different soft spots. And there's a whole field of science that basically tries to look at this, called behavioral economics. And if you try to do this correctly, maybe you can nudge them the right way, which apparently you can. So we created a whole systematic approach. We sent a lot of different messages. We collected all the data. We analyzed who should do this. This was work that was spearheaded by Adi Berliner now in BGU. And the result of that was we had selected the right general message. You know what the message was that was most impactful? Would you imagine? What would it be? We had things like, the system will lose money, that your physicians would be angry. We've tried a lot of things to have, to meet the soft spot. You know what made the most difference? Saying to you that we need this appointment to help other people. So you have to be kind and let others take part. And this worked like a charm. Not to everyone, not in every circumstance. We had to adapt this. But at the end of the day, we had a reduction of no-show in 33%, still valid today, in outpatient hospital clinics. And advanced cancellations up in 17%. So this is working. Now, risk stratification by itself is clear why you would want to approach those people with a high pretest probability. So you would think that once you have your assessment of risk, you can have the intervention done fairly straightforward way. You'd go for the highest risk and you care for them. But that is wrong, because in many instances, the people at the end of the pyramid of risk are least amenable for change or for the impact of the intervention you need. So it is actually that it's not the highest risk that you want to get to, because here the impactability is too low, and you actually, and you can actually model this one. And you want to go for the intervention, not for the highest, but actually somewhere here in the middle, which is what we did in a program in which we had a nurse-led intervention of older patients. And what we've been able to show that through this intervention, we could reduce admissions by selecting those by a predictive model and then intervening. We had a reduction of 43% in admission days on these multimorbid patients. So there's a great return of investment if you go ahead and you do this right. This is not just the right thing to do. It's really has an impact. And we have a lot of, the lights on your car that tell you when, the oil is down and maybe it's time. We have now the technology to have all of those available to us. But still, the gap between tech and care is actually becoming larger and larger because we don't implement quickly enough. And when you go into a hospital and you look for everything that I've just described to you, there's nothing. But how can that be? I've shown you, we've done this in 2010. We're now 16 years later. And there's nothing of all of this in the hospital that you go to. Why? Because they don't get paid to do this type of care. Because they get paid to put heads in beds. And if you do something that takes away heads from beds, you're not doing well for the system. So in most countries, that doesn't make intuitive sense. But at Clalit, when we're big and we have a lifelong outlook and we get paid by capitation, we make ends meet by keeping the patients healthy. So, that's not bad for the economy if you look at some of the statistics. And we actually put forward apps that make sure our patients would walk. And we give them points, golden points for walking. And as they kind of consume those points, they increase their physical activity. And we now have evidence to suggest that there is a lower rate of basically of new onset diabetes and myocardial infarctions in those people who walk more often than others. And if you take a look at the overall statistics, this is OECD statistics of mortality from preventable causes. This is where we are. And the healthcare in Israel is Clalit. Clalit takes care of only 50% of the population, but on the poor and the peripheral, 50% of the population. So this is what's happening. So this is one reason why it's not happening everywhere. The other reason, there's a huge gap between innovation and practice transformation. These are very different terms. Doing research, not that it's easy, but it's more feasible than when you want to create a system-wide practice transformation. This is hard. This is really, really hard. Because, first and foremost, physicians are too busy. You bring them the new shining whatever, and they don't have time to deal with this practice change, even if it's in the long term good for them. So my formula that I want to suggest here for what is acceptable AI has 3 components in it. It needs to be useful, it needs to be frictionless, and it needs to be trustworthy. Let's work one by one. Useful. So right now, physicians need 27 hours a day in order to provide the preventive care according to the guidelines. Anybody here can do this? Okay, so we have a problem. Only 8% of the US population actually gets this type of care. And when I studied medicine, we had 5 types of diabetes medications. Now, you all, most of you come from the same period of time. We had metformin, we had sulfonylureas, and some kind of combination thereof, and tuck, 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 insulin. Life was simple. Life was sweet. Now, 89 agents. 4,500 potential combinations. And in order to make the decision, you need only 335 potential features. Don't worry. All you have to do is find those in the patient record in real time, put them in the 350-page guidelines, and you're there. Oh, and you have 8 minutes for the entire visit, including getting undressed, getting dressed, having the discussion. Sounds feasible, right? Anybody can do this. And now we add in lots of additional stuff. So right now we already have whole genome sequencing of 50,000 people at Clalit. We have exome now workout for every one of our potential be parents with some risk. There's a lot of data accumulating that can come and fit this, and it does. So how do you make all of this frictionless? Basically, if you just go ahead and throw those predictive models on those patients, on those physicians, they will not be happy. They don't have time to deal with all of those predictive models. What you need is somehow to combine all of those into a one-screen summary of a clinical bottom line, which is really hard to do. But that's kind of what we try to do. And there's this system called CPI that took, how long now? 5 years now? To put into practice? 5 years to make this from theory to practice. So it does 2 things, 2 simple things. One is tell you who you should meet this week in order to do this kind of car shop thing that I told you about. Who's going to be sick, therefore you're going to bring them today, therefore you're going to prevent what's going to happen to them. And basically this is how you look at this, and you have their severity rank, and you have to know if they're focused, and this is all explainable AI, because it tells you why this patient was flagged, not only if it was flagged. And then you have a clear summary of what you need to do. You need to switch their diabetic patient, treatment from X to Y, because 5 days ago they went through a blood test and apparently they have now a renal dysfunction, and therefore they need to switch their drugs. And it's all there at site. And with a click of a button, it turns into a recommendation. And not only that, an SMS goes to the patient to tell them a modification just happened even if you weren't in the room, and it was AI driven. And this is happening right now. And it feels for the primary care physicians who usually works alone as if he has with him a whole team of experts that provide them real-time advice on their specific patients, which is a great feeling for them. And they need to trust it. And so these are some of the things. All of you who have worked with clinicians, they are not a grateful bunch, okay? They are even, and then you go to Israel and there's an extra layer of friction there, okay? So to get some good things told about a system is quite difficult achievement. This is a real achievement unlocked here. And they're saying, the system gives me the feeling that I'm finally doing what I studied for so many years, true preventive medicine. Isn't that great? So this works. How many of these happen in a month? You'll know soon. So this is now, this is signs all over Israel. We're not hiding from our patients that we're using AI. We're celebrating it. Okay. Now, as I told you, hospitals are dangerous places with a lot of harm being done there. And we want to move from human-level diagnostics that we have now AI assistants. For instance, every patient who goes and gets an X-ray gets a little yellow rectangle that says to the clinicians, the fracture might be here. This is now daily practice at Clalit. But we want to go to superhuman diagnostics. For instance, you can make predictions from CT scans, even if they weren't meant for that. So you just went for your usual CTs. In the CTs, we can see a vertebra. If we can see a vertebra, we can say whether or not you have osteoporosis, whether or not you're going to break your bone. And this is now quite a while ago. This is 2020. The work was done in 2018. So you now have capacity, which is another superpower we provide our physicians, which is to do superhuman diagnostics. You can look at this. This is a normal staining, hematoxylin and eosin. It's not any immunohistochemistry. You should not be able to tell from this pathology scan what happens to the receptors, but for some reason, computers can do this. Neural nets can tell you things that you shouldn't see. They can look in your retinal scan and say if you're a male or female. And they've been doing this now for a decade, saying in 99% accuracy whether you're a male or a female just by looking. Why would that make sense even? Why would someone look at the bottom of your eye and say, how? But they can. So they can. A lot of things can be done. The problem is actually different right now. The problem is called de-skilling. Physicians are getting used to working with those tools. In this case, they're identifying in their colonoscopies where the lesion might be, and they get so used to it that when you take away the AI, they're not as good. So what happens when somebody pulls the plug in 5 years?
Why is this a bad thing? Are we envisioning a future when, I don't know, all electricity goes away?
That's a fine question. The problem is what happens when the plug goes away or when this becomes too expensive to sustain, and it's a question. You can show the same thing about navigation. You say, yeah, the fact that I have Waze, does that mean that I do not know how to get from home to work? Depends. If in your generation, probably not. But some of our kids might not have the basic skills to do this when you take this away. So the problem is no longer of de-skilling, it's of never skilling. It's people who will never, ever have the capacity. When you have the pilots, they do very good training to see what happens when the machines go off. So they are able and trained to do this. I'm sure with the lack of redundancy in healthcare, we will not have the proper training for the never skilling. And that is going to be a problem. And I would tell you that this is going to bite us sooner than later. We will coming very soon to a point in which a diagnostic test read without guidance would become substandard care. People will be sued for not using AI in the coming 2 years. People will be sued for not using AI in the coming 2 years. And one of the nice things that they say, yeah, but there's the systems, they're imprecise, etc. Oh yeah, like your practicing physician is precise. Compared with what? What is the accuracy of your GP? You don't know. So how are you willing to take care for someone you have no idea what their accuracy is? And if it's 70%, would you still go and see him? Of course you will. So no comparison, no problem. Right now, Lemonade is putting a system outside. You will pay less car insurance if you would let the car drive itself. I repeat, you will pay less for your car insurance if you let the car drive itself. So maybe this will not happen through suits, but maybe just medical insurance would say, you're a physician who practices without AI. That's okay, that's okay. You just need to pay 10 times the insurance. And other than that, keep doing what you feel comfortable with. This will happen very soon. And right now, we already know that AI is better than MDs, and there's randomized control trial coming in the last 3 weeks, huge randomized control trials showing this properly. Until now, it was just hearsay. Now it's evidence-based, okay? The problem is that in some of those trials, the AI is doing great. The physicians is doing not as good. And physicians with AI together, not great.
AI.
How can that be? Anybody wants to guess? The human is in the loop. That's the promise. The human's in the loop.
The trust issue.
Oh, the trust issues. The human rejects the loop. Okay? There's no loop. Trust is everything. And when you don't trust the system, it's of no use because you just ignore it. You're correct. So we need to build trust. It goes back to what I said before. You have to build trust. And doing this type of work in a healthcare system is a horrible, horrible experience, I have to tell you. It sounds like joy, right? So I'm going to work this morning. They're able to do stuff. They do what we tell them. It's fantastic. This couldn't be more different. It's horrible. It's like, you need to persuade the clinicians, and you need to get the IT to comply with all of their spaghetti legacy systems, and you need to get the CFO to give you the money to play and do all of those things. And the information security says, no. And at the end, the alligator. You know who's the alligator? That's the pilot. That's where good projects go to die. Because you should never do the pilots. And it's a problem, LLMs are horrible. It's like having a whole army of really good engineers. The only problem that they're drunk half the day. And you never know which half of the day you've hit. And so it's a great promise because they're really good. You just don't know when they're drunk. This might be funny because we've all experienced this in our travels when he said, go visit this place, this beautiful, and you take a detour and you go to this, it happened to me my last visit in I think it was Slovakia. He said there's this fair day in this castle, and we went all the way to this castle and went in, there was nothing. It was a pure hallucination, and we didn't check it properly. So that's okay, but not when it comes to healthcare, and we're beginning to get evidence of this really causing real harm. So we need to somehow do some kind of governance, but governance is really hard. I sat in a group of really smart people working with the Secretary General of the United Nations trying to create rules of conduct on how to do responsible AI. At the end of the day, we understood this is going nowhere. Governments will not be able to govern this. And we said, things like FDA approvals will no longer be relevant and no longer be enough. Lo and behold, 30 days ago, FDA just said, I'm yielding. No more. I will not give any approvals to any decision support systems. Godspeed and good luck. The responsibility is on you, the organization. And organizations that do this well will be good, because some people are afraid of regulation, but I will tell you that cars with better brakes, they drive faster. So by creating better brakes, we will do faster. How do you do better brakes? You'll hear in a second. But we've created a whole responsible AI governance system at Clalit, locally tailored and implemented, that actually does the trick and allows us to do this. A last 3-minute glimpse into the future. So right now, we are in the point in which we call the whisper, where you have this AI system who sits near the doctor and whispers in his ear what he should do, like this or like that. Physician makes the final call. We're all pretty comfortable with this, right? Next level is what we call the navigator, which means it is the AI that will decide which images you will read first. And as we know in the practice of healthcare, those who go last will never be read. So that's kind of an autonomous decision, but still, at least in theory, the bottom line decision is for the clinician. But very soon, AI is going frontline. And AI will care for patients. And AI will provide care. And like in the past, we couldn't even conceive that we will give the responsibility to a nurse practitioner because she didn't go to med school. And then to physician assistants. New member of the team. Get comfortable with it. Because that's where it's going. And as you know, it's really interesting. They never tire. They never get demoralized. You just keep working, which is fantastic. And AI will no longer be a tool you install. It will be an evolving colleague that will require supervision. And this is the challenge of healthcare systems right now. It's how to manage those new agents that come to play. And right now in this country, they're already allowed to prescribe drugs. In Utah, starting 3 weeks ago. So congratulations, this is a bold new era. Yes. So the gap keeps on expanding. In the last few weeks, this guy, who's not the dumbest person I know, Andrei Karpathy, some of you might have heard of him, he says he moved from 20% of his codes being done automatically to 80%, and that happened in a month. This is the rate of change. We do not know how to deal with that. But it gives us a real chance at this new healthcare paradigm. And it's very contradictory. On one hand, it will de-skill physicians. On the other hand, it will waste resources, but it will also give us a 10x or 100x productivity. All of the above is true. And the road is going to be quite winding. But at the end of the day, I'll end. And we will hear about the in-depth of each one of the points that I've made in this quick tour. It will make our profession better because it will take away the technical parts of our profession, give it to those agents, and we will have time to go to the glory of the profession, not being a clerk, but actually being able to provide care. And empowering our patients to be involved in their care as well. So this will be a new, bold era, and I couldn't be more happy that this is where we're threading. There's a lot of risks there, but overall, this is where it's going, and I think that this builds on a lot of collaboration. So the aim of this is to invite each and every one of you in the days that are coming to be discussing how we can work together to do this better. And with that, I will move to, so it's separate? Okay. So thank you. So this was quick, but now we will go in depth. Noah, the floor is yours.
I have my own. Okay, so I really hope Ran was able to convince you that we really do have a dire need in health for computational methods and for AI specifically. And that, like, beyond the fact that we really need these tools really have an opportunity to do real impact, real transformation in care in a way that is beyond some anecdotal projects and deployments here or there. And basically, what I'm about to show you is why it's so hard and why everything in the process needs to be really, really looked into in depth in order to make sure that you're doing this the right way. And this is challenging, so you really need to believe in the cause. So that's why I really hope that Ran was able to convince you that everything I will show is worthwhile, because at the end, we're doing something really, really great. So we'll talk about responsible AI. This is the outline of what we'll be discussing. So why is it hard? Why is it so hard to do responsible AI? And we'll start the discussion in general, a scientific discussion about it. At some point, we'll give the specific example of how we do it in Clalit as one use case of one AI governance process that we've created. We'll speak about fairness and values in models, about the need for logging and monitoring, and finally, the most important part about impact evaluation. So why is responsible AI so difficult? We are working in a conservative domain. It's not new. We have technologies in medicine. They've always been regulated. We've always trusted the regulation. We never asked ourselves, what is the responsible way of using pacemakers or Tylenol? As long as there was an RCT, a randomized clinical trial that was conducted in the right way, right inclusion and exclusion criteria, trustworthy process, we trusted the same technology to be working as well as was reported in the study in different settings. That's not the case for AI. In AI, we see again and again, the literature is full of these examples. We have a great model in one setting, it was trained, it was properly tested, but when we deploy it in a new setting, there is not a low chance that it will stop working as we expect it to the level of complete randomness. Why is that the case? Why is that everything that worked for classic medical technology is no longer working for AI? I like to think about it as a change in the substrate. The substrate for classic medical technology is the human body. And the human body is pretty consistent. We have some genomic variations, but enzymatic processes, molecular processes are basically something that works in a very consistent manner across the globe. And when we tested Tylenol in one place, we expected basically to work the same in another. For AI, the substrate is data, and data is completely different in different healthcare systems. We can take two identical twins. If they are treated in different systems, they will have completely different data. And once a model meets new data, it can behave in an unanticipated manner. And the numbers basically speak for themselves. We see many, many, many papers coming out on both sides of this phenomenon. One is the effectiveness. The models are not working as we expect them to. we see one performance metric in the development setting and a completely different performance metric in the deployment setting if it's like new data, new rules, new performance. And the same goes for like what we call the side effects of AI models. So these unanticipated behaviors that are really hard to detect. For example, the model not working well for specific subpopulations, and we will never know if we will not test for these things. So on the one hand, we have so many papers coming out showing that the performance metric, the effectiveness is not what we expected to, and so many other papers coming out basically saying you have these weird behaviors in your models that you are not aware of. Be careful. And Ron talked about classic regulation. Look at the number of recalls from the number of approved AI products. The reason that it keeps happening again and again is exactly that. The bottom line. Some available performance is just, and some available authorization is not sufficient to guarantee performance in a new setting. And this is very, very challenging.
Now, can I ask,
Sure.
is it the substance or is it the way we are actually evaluating it? Because if you think about drugs, for example, you have the phase 3 and you kind of sell the product and nobody is actually evaluating the actual effect of these drugs in the real world. While all the AI tools are truly mathematics, and it is very easy to evaluate their value in the real world. We don't know anything about
real medications.
Yeah.
Real medications about
Real
drugs. There are phase 4 trials everywhere. I think that this is classic practice. I agree with you that we can know for sure that it's not that we have these ongoing real world effectiveness trials for every kind of drug. But I think, from my medical point of view, it's much, much more consistent because, Tylenol will work the same in different places. It maybe the effectiveness is slightly different for different subpopulations, maybe slightly more effective or slightly less effective. It's not like you put it in a new population and the drug just stops working. The enzymatic process that was affected just is not affected anymore. It's not to the same level. There are some variations. It's not to the same extent. This is dramatic. Sometimes it just doesn't work at all because the way it worked really depended on the very specific data setup that was existed in the place where it was developed. And the whole system of how we do regulation on all levels of regulation is basically based on the fact that we can anticipate performance. But at the end of the day, healthcare organizations need to make that decision of deploy or not deploy. And they know that they can't rely on these approvals because they have different data and they don't know what will happen to the model once the model meets their data. So basically there's a new level missing of the organizational level, the healthcare organizations, because they have the data. So only these organizations will be able to try to assess whether or not the model will work for them. No one else can access their data to test it for them. But the question is how? How do you do such a process? Healthcare organizations never took part in the regulation. We always relied on external regulation. So what can we do now in order to make sure that we are deploying AI in a responsible manner? And when we asked ourselves that question, we read a lot of literature and basically came to the conclusion that there is a real scientific gap. There is a lot of literature about responsible AI, about documents, very long documents, hundreds of pages, saying what you need to be careful of, what you need to consider, what you need to think about. But at the end of the day, if you are a healthcare organization and you're trying to ask that practical question of deploy or not deploy, there was a complete gap in the literature. So at some point, we took that challenge of trying to bridge that gap, trying to basically create a tool, a generic tool for healthcare organizations that will help them to evaluate whether an AI solution is appropriate for their setting or not. And the challenge is, how do you take, a very long list of dimensions as a healthcare organization and make sure that this AI solution is appropriate in each and every one of these dimensions for you. And this is how we ended up creating Optica. So Optica is an organizational perspective checklist for AI solution adoption. It tries to really solve these two problems, answer the question of whether or not this tool will be effective for your healthcare organization and whether or not it will have these unwanted side effects that will surprise you at some point. The way we chose to do this was exactly that scientific gap I discussed. To really consider the unique perspective of a healthcare organization that has a very specific population and very specific data set, to be very practical and down to earth, and a very structured process of clear, defined questions that says who needs to complete each question and in what order when you take into account all the different checklist items that might affect one another. And this is how it looks like from a high-level point of view. We won't go into all of this, but basically it defines 4 different domains, 13 sub-chapters, and you see 5 stakeholders according to the colors of who needs to answer what question, and the order, the letters, say how the process actually works. So this was published as an open source tool for healthcare organizations. This is the group of collaborators that contributed to this process, each one contributing their own expertise and scientific point of view. And we really think that it hit the right spot because we are getting a lot of questions from a lot of healthcare organizations, and we see more and more organizations adopting this thing as parts of it or the full thing, basically trying to translate that into something that works for them in a way that, again, bridges that exact gap that I've talked about. So Optica was really created as a scientific exercise, but I think it really got to the point where it really was able to answer that need of creating something very practical that healthcare organizations can really adopt. And Clalit was one of these healthcare organizations. So after this paper was published, in 2025, Clalit went through a process of creating an AI governance system for how we take in new AI products. And because we tested Optica on several AI solutions, and each and every time we found critical issues that were identified by Optica, and it didn't matter what was the kind of tool, the kind of algorithm, it didn't matter who developed it, whether it was an internal development or some off-the-shelf product. Each and every time we saw critical issues that either said this tool is not appropriate or said, oh, maybe it's appropriate, but do these changes in order to make sure that it works as you want it to. So after we tested Optica ourselves, Clalit and the AI governance in Clalit decided to adopt Optica as the tool for its AI governance, but made some changes that I will show in a second. The first thing that was done was to define where and when we need to apply this tool. So basically, whenever a tool or a solution, an AI solution, is about to meet patients, this tool needs to be in the process. And it doesn't matter if it's research, if it's deployment of internal R&D or an off-the-shelf product, it is there. If it's just the development phases, if it's retrospective data, if it's built in a medical device, so the device creates its own data, so it's much more consistent, then it's not part of regulation. Otherwise, it's in. Clalit did 2 additional changes. One is to add 2 stakeholders to the mix. And the second change was to add some additional phases, because the tool Optica was, again, created in a general fashion. Here, we actually transformed it into something that is an organizational process. So it broke the different phases into something that is very, very, very practical, down to earth, introducing a risk stratification phase that defines the risk of the AI solution, so that the amount of checklist items that will be completed will be based on that risk, introducing an AI committee for high risk solutions, and a yearly process that you can see, on the right, in which 2 new checklist items are being completed every year about the monitoring and about the impact evaluation to make sure that the product is trustworthy in a continuous manner. So Optica was a tool, a generic tool. This was a specific use case from a single healthcare system that took that tool and translated that into something that works, defining who completes it, when, and for which kinds of solutions. So that was the overall framework. Now I want to dive into specific aspects of why it's actually challenging and what's actually inside that process. So fairness is something that is at the core of medicine. It's the core values that we are being taught in med school. And when we are implementing AI in medicine, we need to be, held up to the same standards as the entire practice of medicine. And a few years ago, we thought it was hard. We were in the era of machine learning models. We, as everyone else, looked at the overall performance metrics and thought that if they were okay for the entire population, that they're probably okay for us to deploy. And then some smart people came to us and said that that's not the case, and we started to look at specific subpopulations, hundreds of subpopulations, and once you look under the hood, you see a lot of miscalibration for subpopulations. And miscalibration basically means that the model is not performing well for that group of individuals. So it doesn't matter that it works well for the entire population. If it doesn't work for specific patients that will receive these predictions, it needs to be fixed and corrected. So we worked with great people in this room in order to implement this. And this work was led by Noam. And basically, I think we learned that even the classic ML was much harder than we thought. And then we started to implement these prediction models. And Ran already talked about CPI and how CPI basically helps to do proactive medicine. As of this year, every primary care physician in Israel, in Clalit, is entitled to 2 hours a week in which they basically block the appointment book, and they can decide which patients they want to see using our systems. So this is a huge responsibility. And the way we rank patients for proactive interventions is according to the AI models. And even if the AI model was perfect and well-calibrated, even multi-calibrated, it turned out that it's not enough. Because physicians kept saying again and again and again, maybe your score is perfect. Maybe your crystal ball is performing, like the ideal predictor. But it doesn't mean that that's what we want to see when we look at the proactive intervention list. Because, do you have any idea why? Why the predictor that really predicts accurately who is at the highest risk is not enough to create this list of proactive intervention lists for patients?
Who would harm, what do you call them, and also who would gain?
So adherence, that's one thing, and who would gain, that was the main point. The highest risk patients are also relatively old patients. When you do proactive medicine, maybe you also want to prevent diseases for younger patients. So you need to find a way to integrate age or life expectancy into the mix in some way. So we did that. That was also not good enough for physicians. So we identified high-risk patients that were also at the age that was reasonable in their point of view for intervention. It was still not enough because actionability. If you have a very high-risk patient that is maybe even young, but the current treatment is perfect, you don't need to do anything about it. So you somehow need to integrate the risk predicted by the AI model, the age, or some sort of other proxy for life expectancy, and a list of care gaps that is very high dimensional. There are a lot of different potential care gaps, some more substantial, some real care gaps, but not that critical. How do you take all this information and create one proactive care priority ranking that is meaningful and will be accepted by physicians? And it turned out that this question is really, really challenging. Why is it challenging? It's challenging because there is no gold standard. There is no literature. No one does this type of medicine, so no one encounters these questions. So how do you start when you don't have the correct answer? You don't have the label like you did in ML models. In ML models, you knew, heart attack, okay, this is the label, yes, heart attack, no heart attack. I have the predictor, I have my AUC, I can make sure it's multi-calibrated, but I know where I'm standing. Here, how do you combine these things? How do you even start? And at some point, we said, okay, we can try to take clinicians' intuition and expertise. Maybe it's the closest thing to a gold standard, but then how do you take their black box inside their minds and translate that into the ideal ranking? Clinicians will find it probably hard to rank entire lists. Humans are not good at this task. And they will find it hard to take a multidimensional problem and say, this is how these 20, 30, 50 features should be integrated in order to create the perfect ranking list. So at some point, really smart people, some of them sit in this room, Matthew, suggested that we can create a different kind of process. And since then, Maya and Maya here are leading this series of research projects in order to try to answer these questions. So one insight was clinicians are not good at creating full lists, but if you will present 2 patients at a time and just ask them to create a pairwise choice ranking, they will be able to do it. And if you do that and then you train an AI model that learns the ranking, then the AI model will be able to tap into their minds and to do that thing that they cannot do explicitly. And if you do that in a circular manner with active learning, you can do it pretty efficiently because each time you'll choose the best pairs of patients to be ranked. And at the end of the process, we can test it on a held out set and see how well we did. So this is how we do this. This is one of the interfaces that we're using. Personally, I have PTSD from seeing this Streamlit interface because I've ranked hundreds of these patient pairs. Each time that we're changing the methodology, we need test subjects, and I'm a willing participant. So this is how we do it. We present some features, and we basically ask patient A or patient B or X or Y, and how sure you are in the decision. And then we are basically trying to learn what is the most effective way of sampling these patients, both in terms of how do you choose the first pairs for ranking, and then should or should we not integrate an active learning process? And if we should, what kind of active learning? Because there are a lot of ways to choose the patient pairs. And what is the best learning model that we can use in the process? So first, preliminary results from simulated physicians showed us that RankNet, one of the ranking models that we've used that is based on neural networks, is the most efficient model to learn these kinds of behaviors. And also that really depending on the type of performance metrics that we are pursuing, it depends on whether or not active learning is efficient. So if we're interested in the top of the list for the ranking, which we are because its proactive intervention is done on the top of the list, then active learning becomes really, really efficient. And we're seeing it again and again. This is like learning curves of these types of models. And when you look at the right side on the NDCG, you can see that the active learning methods are much more efficient in reaching high performance compared to what the physicians want to see if we're talking about the top of the list. You had a question, Rina?
Yeah, so if I understand correctly, what you're trying to learn is you're trying to learn the physician preferences over who should be prioritized.
Yeah.
And we just had a whole talk about how physicians are so bad at so many things. Humans are so bad at so many things. And also we know humans are super biased. So what could we do in order to generate data that could let us learn something that's better than humans in this space?
So ideally, we'll have what we call QALYs, quality adjusted life years, for each type of care gap, for each individual, for like hundreds of individuals. And Ron just also, yeah, clinicians are not ideal decision makers, but clinical knowledge stops very high level in a very average kind of way. Most interventions in medicine, we don't know the quality even for the average population, let alone for the individual patient. So we don't have any other alternative. And I've spoke with, like, I think dozens of physicians, dozens of philosophy experts, and like whoever we could ask over the last years, because this is a real challenge for us. The closest thing we got to is still the clinician intuition, because the intuition of who will, who will gain the most health from the intervention is still something that clinical intuition is probably the closest thing that we have. So maybe a clinician is not, could make mistakes when they choose one from dozens of diabetic medications for a specific patient. But if they will sit long hard on the patient's record, probably they'll make the correct choice. The reason that they're making mistakes is because they're not taking the time, because they don't have the time, because they don't have access to the full record. When they are presented with the right setting, they will probably make the correct decisions. And here it's much more of a, an intuition based of a decision. So as of today, I still think that physicians are the closest thing. I'm completely sure that other types of models are not well equipped to do these kinds of decisions.
Do you have a sense that after physicians had one of these interactions, so we brought somebody in, sort of according to the model or whatever, whether they have a better than random sense of whether that interaction was beneficial? And could we use that ranking to try to improve? And maybe even bring in some random people in some sense in order to get some better data?
Yeah, so clinically, I don't think a specific interaction with the patient will let them know if, like, this clinical intervention, they know that. I think what Omer was addressing before, maybe the adherence is something that maybe at some point they will be more well equipped to try to predict, because this is a new type of medicine. But they're pretty good. Usually, these are primary care physicians. They know their patients so most of the time they're pretty good at also knowing how the patient will react to this kind of interaction, new medical interaction. So it's really hard to do some medical intervention then deciding was efficient or not. Sometimes it will take years. You're trying to prevent a heart attack that will maybe or maybe not manifest in 10 years into the future. So I think a lot of this is clinical knowledge and intuition of patients that they've seen, not a specific encounter that will basically inject more information into the system.
Okay. Now, when you have to make a list that the physician is going to read, then you have to think of who is going to be on top of the list and who is going to be down on the list. However, you can give in each and every encounter with each and every patient I'm seeing in the clinic, you can give me kind of a suggestion, and I can take it or not take it. And then I already see the patient. I can tell him or not tell him your suggestion. So you make me superpower without taking time from me. And then you can actually judge whether I took your decision or not. And when you are making the list, you can take what you have learned about these encounters and put it on the list. I know that the list has advantages since you are going to approach people you are not approaching in the clinic, but you can combine it.
This is exactly what we're doing. So currently, CPI has been working for years in the way that you've just described. When patients enter the physician's office for any kind of reason, we have an alert, not a pop-up, an alert on the side of the screen saying whether or not CPI has recommendations and whether or not CPI has meaningful recommendations, because we don't want the 8-minute visit to be stopped if we only see that this patient is missing 4 lab tests, but that's not critical. If the patient is receiving the wrong medication, we want this visit to be stopped and interrupted, even if the patient came for a completely different reason, and it will take you more than 8 minutes to address the first reason he came through the door. So we are doing exactly that, but it turns out that it's not enough. Like, the amount of care gaps that we know of for patients who are at high risk are enormous, and we can't just keep waiting for them to come in and to really be hopeful that the physician will have these 2, 3 extra minutes in the visit that is already stressed and really short to do this extra care. So basically, we're trying to do both. We will present everything for every patient that comes in. We will always have every type of care gap, even if it's minor. But we will try to do it in a gradual manner. So if it's substantial, we'll say this patient has substantial care gaps when he or she come into the door for any reason. And if it's super substantial, giving the crystal ball and the care gaps and everything like put together, then we'll rank this patient for proactive medicine to be at the top of that pyramid that Ron discussed. So yeah, it's both.
Because we assume that the physicians are fair, or because where is the fairness coming in?
The fairness is the challenge because, as Yair just said, we are deciding to put someone at the top of the list that actually translates into someone else being at the bottom of the list. So you need to make these choices in a fair, ethical way, and we need to somehow solve this. Once you implement these kinds of systems, think about the amount of power you have in your hands as to who will receive extra care and who will not. Like, you need to do it in a fair manner. Like, we are super worried about this superpower that we just received.
I guess I'm asking the definition of fair here would be, because we're trying to imitate what the physicians would say. So the definition of fair here is if the physicians are probably going to do it in a fair way, and so we're trying to imitate a fair behavior?
The fairness is the challenge. What is the solution? I don't know. We have our thoughts. I don't know if that's the best solution, but currently I think that the most fair solution will probably be maximizing the health utility that will come out of the process. And I think the only player in the system that has this intuition is probably the physician. So this is an exercise in trying to tap into the intuition of the physician, because we think that's probably the fairest thing to do.
I'm sorry for laboring upon that. I get, because I'm the session chair, so I'm allowed.
So you'll give me extra time.
I'll give you the 3 minutes of mine. But do you ever, I mean, they all raise this super important point of, do you ever question the physician's preference? Like, at least at the margins, are they biased?
Great question. Because after doing these exercises with simulated physicians, because it's a lot of effort, a lot of algorithms, so we can't waste so much time with physicians, we went to real physicians. And here we took 5 primary care physicians and 5 public health experts and asked them to complete, me being one of the public health experts, asking them to complete these, hundreds of pair rankings in a rolling manner. So you get the batch of 100 pairs, you rank them, someone trains the model based on your preferences, you get another 100 pairs for ranking, and this goes on and on. And you can see, for example, an interesting finding for us was that public health physicians, for example, look at the age. Public health physicians in blue tend to give an average ranking that is higher for younger patients compared to primary care providers. Because we are used to this thinking of preventive medicine, this is our practice, this is what we do, this is what we preach. So it translates into our bias, this translates into our preferences. And vice versa for the risks, because basically younger patients are usually at a lower risk. So for high risk patients, the primary care physician ranked them as higher. But so we have our own biases. If anyone in this room can think of a better solution, I will be really the first, literally the first to really be eager to hear it, because I don't think it's ideal. I think it's the best solution that we came across until now. But this is exactly why I think this meeting is super important, to try to bring these kinds of challenges into the kind of mindset that this room currently has. Maybe we'll find a better solution. But yes, of course we have biases. We all have our own type of training, and this translates into our decision process. But as I told you, this is very, very intense in terms of time, and physicians' time is a very limited resource. So at some point we've asked the question of, can we use LLMs to do some of these pair rankings? And this is what LLMs got us. And these are 3 different LLMs. And you see the kind of bias that could result from taking an LLM and doing the same process. So this is very interesting because we just discussed LLMs are making a lot of medical decisions. Patients are, consulting LLMs all the time to make these decisions. And there is really a big question of what are, the values that are hidden inside those LLMs. Of course, physicians have personal bias. Great question. I have a lot of slides about this bias. But it's one physician with one bias. So the impact of that bias is limited. Good or bad, it's limited. When an LLM creates these decisions at scale, suddenly millions of patients will be shifted towards different value set, and we are not aware of these values. We hardly are aware of these values when we as clinicians make these decisions. We're not talking explicitly about the names of the values when we make these decisions, but obviously they're there all the time. Who do you help? The worst off, the highest risk, or the younger patient? Like maximal utility or maximal help the worst off? So the values that are there all the time. LLMs integrate these kinds of values into decisions all the time. If we do not ask the question explicitly about the types of values that these models are basically manifesting, we will never know. So these kinds of discussions were some of the trigger, along with other triggers, for a very large group of experts meeting together and basically releasing this consensus statement that says that what we are currently testing, model cards, even fairness, multi-calibration, these kinds of things, is not enough to disclose the hidden values that are being manifested in these decisions by LLMs. And we suggested as a group that we need to create a way to look under the hood of these models and to create these VIM framework, values in the model framework, that on the one hand will ask developers to explicitly state whether or not they, in the system prompt, for example, ask the model to follow a specific value set, and also try to create this clinical scenario benchmark in which we'll create vignettes, stress test these models, and see, at least being able to explore what kind of values they follow. And there is no correct answer, but let's at least know whether or not it's completely different from the value set of current clinicians, patients, stakeholders, policymakers, whoever you say this is the correct group to make these discussions and these decisions, at least know whether or not the LLMs are completely skewed, like we saw in our example for the patient rankings. 10 minutes? Plus free. So let's go on to talk about logging. So again, I said that the problem with responsible AI that we've just discussed, 10, 15 minutes about one challenge, which is the fairness and values. But we have several dimensions of these challenges. One of these is continuous logging. So this is a great collaboration led by Ayush Nouri and Marinka Zitnik from Harvard Medical School, basically creating another consensus statement that we need to log everything. And we need to log everything in a consistent manner in order to be able to then recreate a lot of these insights. So it's called medlog. It's based on the idea of syslog from Linux systems that basically say, let's log every interaction in a systematic manner, no matter if it was with the provider asking a question about the patient, or a patient asking the model, or the model, like two AI agents interacting with one another. It doesn't matter. We always have the same building blocks of things we want to document. And this is the group of people they were able to bring into the table to agree on this setup, because it seems trivial, log everything, but it's not trivial, because when you don't say it explicitly, you don't do it. And if you don't do it, you can't get to proper monitoring. So the next challenge is proper monitoring. And again, a few years ago, in the ML era, we thought it was challenging. How do we make sure that every ML model that we put into practice is working in a continuous manner without any data drifts? So we created these systems that monitor the distributions of every input, even if it's hundreds of inputs, and every output, and to try to tap into the continuous performance metric of the model. And these systems were hard to create. Again, we thought it was hard back then. And they really proved themselves, because this is a real life example from one of our models, a model that tries to predict the risk of hospitalization in CPI. And at some point, that model in March 2023 started to give us alerts that something is going on with the LDH feature, because something in the distributions feels like slightly shifted. And look, it was almost identical back then. And this is a simulation of what would have happened if we would just let it to continue. And it turned out, after exploring again and again what happened to the LDH test, was that at some point we got to the people in the laboratory that told us, oh yeah, we switched the LDH kit. So of course the values are now completely shifted, but if we would not create these monitoring systems, we'd never find this feature starting to deviate. So again, we thought that was hard, but what do you do with the LLM answers? How do you monitor free-form answers? So, this is a Gen AI system, a chatbot system based on RAG for pediatricians in Schneider Medical Center. And they have more than 1,000 protocols, and we create this chatbot that basically tries to give them accurate answers based on the protocols. And what we see here is that we are challenged with the question of, is this answer good or bad? But the challenge is that there are no clear labels. There are no standard accuracy metrics, recall precision with clear labels. We just don't have this privilege anymore. So if you thought it was hard back then, now it's really hard because quality is multidimensional. Answer should be complete and concise and faithful and no hallucinations. And the quality is very subjective. You can have multiple good answers and multiple bad answers, each in different ways. So again, the closest thing we have to a gold standard is the human expert. But the human expert is a very limited resource. So what do? We don't have any other option than to use other LLMs as the judges of these kinds of answers and to try to use them as the monitoring system. And then we basically take this output, give it to an LLM as a judge, but then you need to see whether the judge is accurate or not. So if you feel this is a recursive process, it is. And it's very challenging, but we have to somehow try to understand whether or not these judges are accurate or not. So here we took 5 MDs, 5 pediatricians from Schneider. We took 7 LLMs and started to ask questions about the accuracy in different dimensions of safety, completeness, conciseness. And you see that, again, the same phenomenon. LLMs are agree with themselves much more, and PCPs agree with themselves, not PCPs, pediatricians in this case, agree with themselves much more. And there is some agreement between the PCPs. CPI is like too many years of doing CPI. There is some agreement between the pediatricians and the LLMs, but for some metrics. And for others, it seems really, really bad. So for example, for medical reasoning, the agreement is much, much lower. For conciseness, the agreement is much, much lower. For other dimensions, it's fair. But if we don't test these things, we don't know. And we have to put this monitoring system into play because otherwise we just can't know. We're completely in the dark whether or not these models perform well or not. Finally, and the most important thing, impact evaluation. We all talk about retrospective intrinsic performance. I stole this term from Noam. Basically, AUC and other metrics of the model in retrospective data. And rarely people get to this holy grail of discussing what happened after deployment, whether it's prospective intrinsic performance, did the same AUC manifest in real-life deployment? What changed in the world after we deployed? What outcomes changed because we did this intervention? And whether or not this is actually usable and physicians like it and accept it. So Ran gave you the example of the hepatitis C. This is a prospective, intrinsic evaluation of the model performance, basically. And what we really want to ask is what changed in the world? What positive outcomes are we preventing? What negative outcomes, the side effects we might be causing? Ran talked about the de-skilling, for example. These are changes in the world that happen because we chose to implement a model. And the thing about this, and a lot of data scientists, a lot of researchers get it wrong. This is causal. This is causal. You can't treat it in any other way. And the gold standard for doing causal analysis is randomized clinical trials. And this is the holy grail. This is what the literature is really, really, really seeking. RCTs of AI deployments, but it's not always feasible. And if it's not feasible, at least plan a pragmatic trial design, so implemented something in a rolling manner, for example, so you'll have better tools to then try to assess this impact in the world. And if you don't even have that, so do causal inference in the retrospective way. And again, if you do it carefully enough, you can do it correctly. And these are examples from the last few weeks about scribing tools. And if you don't test, you don't know. I think the world was really surprised that these scribing tools save some time, but not consistently, in very small amounts of time compared to what was expected. But more importantly, maybe, burnout and the feeling of physician's experience is much, much better with this tool. So if you don't test, you don't know. And this is what we're currently trying to do for CPI. We're trying to create these causal inference studies to see what happens. And when we use PCPs for being their own controls in the same, even in the same day, appointments in which they opened CPI by chance, and appointments in which they didn't, the chance that they will close a substantial care gap is 2 times to 4 times higher if they chose to open CPI in that visit. And we are currently, our researchers, these are Josh and Rom from our real-world evidence team, causal experts, trying to create a causal setup, a causal system that will basically do all of these analysis in a way that is more consistent. A lot of these tools are like rewritten and are running automatically, but in these analysis, you need the human in the loop and a lot of judgment calls, but a lot of explainability in the process. This is what they're trying to do. And we call it the pan-causal analysis. And basically, we are putting a lot of emphasis into this now. And I spoke about usability and acceptance. Ron already showed this slide of just ask the users. They're so busy. They're so frustrated with life as it is. So if they're choosing to use your system, probably does something good. And finally, the number that Ron did not show. So this is not a causal analysis. This is just a number, but it's a quantitative number that tries to say what is the impact of what we're doing. And the impact specifically for CPI in recent months is 100,000 care gaps that are being closed every month by physicians using CPI. This is not the number of recommendations in CPI. These are the number of recommendations that are being adopted by physicians every month for patients in Clalit. And I hope this is a good ending to showcase that it is hard. It's hard to think about all these aspects of responsible AI, and look how many questions it brings up and how many worries it brings up. But this is the gain at the end of the road if you are willing to take this journey. So with that, I will end.
So you surely have a great many questions for the brilliant talks we just had, but I suggest we do them over coffee and reassemble at 3:15 for the last talk of the day.